Good evening, everyone, and welcome to our Woo You webinar tonight. We are going to get started now with patient compliance, the ultimate goal in glaucoma therapy with Dr. James Timmons. Thank you so much, Dr. Timmons, for being with us tonight, and we're looking forward to learning from you.
Thanks for the invitation.
And where are you located?
Southport, Connecticut, the southern part of the state, large network of practice locations all the way up towards New Haven and Hartford and all the way down to Greenwich. So
Beautiful. Next slide. I'm Dr. Lise Kramer. I'm currently located in Miami, Florida, and I'll be here for housekeeping and also to help answer questions toward the end of the presentation. Next slide. Thank you to Tea for exhibiting at this event. So just a few things before we get started tonight. This is a 1-hour CE course. So for each hours of CE units, attendees must be online for a minimum of 50 minutes in order to get COPE credit. For a COPE certificate, please fill out the survey link in the chat. Also, the survey link will appear when the webinar ends, and CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. There's also going to be a QR code at the end of the event. So if you have the OE tracker app on your phone, you can get instant CE. If you don't have the OA Tracker app, don't worry, we'll still send you the certificate within 4 weeks. And it will not work with your regular camera, so you have to actually have the app in order to use that QR code. You can ask questions using the on-screen floating panel. If you can just go back one slide so I can show them what that looks like on the regular. Yes, so if you see the chat and Q&A, and we'll keep the logistic questions for the chat, and then the Q&A will be questions for Dr. Timmons. Next slide. And if you're using the mobile version tonight, you'll see the Q&A at the top there. And if you want to use the chat, you'll have to click on those 3 buttons at the bottom for the more options where the chat is. And I will introduce our wonderful speaker, Dr. James Timmons. Is a 1978 graduate of Ohio State University College of Optometry. He completed his hospital residency at the Chillicothe VA Medical Center in 1979 and then served as Chief Optometry Service until 1985. He then accepted the position of Center Director at Omni Eye Services, Fairfax, Virginia, and served in that role until 1989 when he became Chairman, Department of Clinical Sciences at the State University of New York. While at SUNY, he developed the Glaucoma Institute, a clinical research center, and served as its first director. In 1998, he accepted the position of executive director of TLC and served in that role until 2002, when he co-founded Ophthalmic Consultants of Connecticut, a multidisciplinary referral practice providing secondary and tertiary level care. Dr. Timmons has received numerous awards for his service to the profession and has over 200 publications in glaucoma, dry eye, cornea, and external disease, as well as refractive surgery and new technologies. He is a nationally and internationally acclaimed speaker and educator and an acknowledged leader in ophthalmic clinical education. He serves in a professor appointments at several universities in the U.S. and has been a clinical investigator in over 20 NIH, NEI, and post-release clinical trials. In 1999, he was awarded optometry's top educator and was selected as one of the top 10 clinicians of the decade. In 2002, he founded the National Glaucoma Society, a NFP with executive offices in Andover, Massachusetts, that provides educational and clinical development services to primary care clinicians worldwide in the area of glaucoma management. In 2005, he was inducted into the Optometry Hall of Fame and has recently served as president, Connecticut Association of Optometrists. Dr. Timmons was selected as the top eye doctor in Fairfield County in 2013. In 2022, he was selected by Newsweek as one of America's top optometrists. Wow, that's amazing. So honored to have you. And these are your financial disclosures. And I will be on later again for questions.
great. Jenna, is it good to share?
You're good to go.
Cool. There we go. Well, thanks everybody for joining us. Really look forward to spending a few minutes together tonight. It's a little bit late for some of you, a little early on the other side of the country, but this topic is literally the essence of excellence in glaucoma practice. And I'm going to approach it from a couple different directions. I want to talk about compliance directly. I want to talk about literature that supports or does not support our patients being compliant. I want to give you a perspective about something new called interventional glaucoma, which is a different thought process about how we manage glaucoma and where we begin the intervention, how we begin the intervention. And I want to share some really exciting developments in the area of technology, both medical, diagnostic, and therapeutic, that have changed my practice and allowed me to control the compliance process at a much higher level. So without any further ado, basic question, what's compliance? Well, compliance is when people do what you ask, or when things occur in the way that you design them and activate them. In reality, as you can see here, the average, well,
your slides are not up. I apologize.
okay, well, let's go backwards then. Take that out.
You might just have to try to reshare your screen.
Yeah, well, let me do that. That's good. Yeah, that's a problem. There we go. Let's get rid of that. All right, let's share now, okay? Are they up now? Jenna, they up now?
Nope, can't see them.
That's practical. There we go. How about now? Better?
Yep, we're in business.
Cool. Okay. Well, we didn't miss much, so let's get back to the action. So, my favorite artist, by the way, Paul Gauguin. So as you can see here, a number of different clinical perspectives share the same difficulty we do, which is chronic disease management is really driven by the ability to achieve compliance. And from a patient perspective, as you know, when you talk to the patients, especially if you're treating them with topical therapy, this is a really beautiful article by Williams in Consumer View, JAMA by Haynes in 2002, that show that patients don't want to be non-compliant. They want to think that you're good. They want you to think they're good patients, and they'll probably tell you whatever you want to hear. And so for that reason, it's really critical that we look at the literature to help understand what we anticipate our patients' compliance will be. This is an amazing study by Mays back in 1984, where he had type 1 diabetics, and they surreptitiously gave them glucose monitors with memory chips. And it was just 40% of the values they recorded in their glucose monitoring catalog, the little booklet, were fictitious. They just made them up because they thought the doctor wanted to hear that type of good news. And so I don't believe our glaucoma patients are any different, better. So let's talk a little bit about maybe making it better for us as clinicians and how we can have a better conversation to at least understand where our patients are and get a true and active perspective about what's going on at each visit so that we can make corrections and help our patients achieve the ultimate goal, which is have good sight for the rest of their lives. First and foremost, really important, begin with an open-ended question. Things like, tell me how you take your medications. Never ask, are you taking your medications? That's a really ineffective way to begin the conversation because the answer is always yes. It is rare when a patient will sit there and just look you in the eye and say, you know what, doc, I haven't done it in 3 months. Sorry. I know you want me to, but it's been busy. Something else happened. Those kind of things. Reverse the judgmental situation. Reassure that non-adherence is understandable. Almost everybody does it. I will readily admit, if I get an antibiotic for an infection, I rarely take the whole recommended dose. If I feel better, I stop. It's normal, it's understandable, but it's not something that is going to make this work long term. And we together need to make sure that this is going to be a project that we can both live with. Enlist the patient's participation. What can we do to make this better? What can we do with your environment? Do you want to take that nighttime drop in the morning when you're brushing your teeth? That's a great time to take it. the literature doesn't support any notable advancement or gain in using medication at night. And then ask about forgetting or missed medications. How many bottles do you have? You know the colors of the bottles? Why don't you tell me about the colors? We know what the colors represent. They don't necessarily do that. And, frequently you'll get, oh, I take that little light blue one twice a day, but I take the dark blue one once a day, which is exactly opposite what you want. You want the dark blue one twice a day. That's your Combigan. The light blue one's one of your PGAs. You'd like that one at night. And these types of questions without judgment, I have found over the many, many years I've practiced that this will open up a relationship with the patient where I do think you get as much honesty as you're going to achieve. This is a really important study, and it was done by two of the great minds in glaucoma, Harry Quigley and Friedman, published in AJO in 2005. Look at the decline, and this is called a continuous loose study. These patients started on a med, and at 6 months, 12 months, 18, 24, 36, et cetera, they looked at how long or what percentage of the patients had continuously refilled the meds and used them. So in the beginning, in that first 6 months, prostaglandins and most of the other drugs are up in the 70% range, somewhere between 4 and 6. The prostaglandins stayed because they're simple, they're once a day, they're at night, they have relatively few side effects that would cause a patient to deviate off of that recommended dosing. But look what happens with ocular hypertension as well. Over there, we have not notably more, but in each case, what we see is a massive decline in continuous use by 12 months, except for the prostaglandins. That's a scary thought that by the time we're out a year, a 25 to 30-year project, our patients are already deviating off the norm. This is a study, by the way, just credit some of these slides. As I was explaining to Jenna, my computer dropped my computer and crashed it. So I had to redo an entire lecture yesterday and today, and I had to come up with some stuff that I had worked with other doctors on. So this is courtesy of some friends. This is Market Scope via the Glaucoma Corporation. So this is public documentation. But this is a really good study. Which of the following best describes your attitude towards eye drops? These are questions to doctors. They're my primary form of treatment. I would probably think that most of us would say that the vast majority of our patients get an eye drop first. I think that's a very fair and reasonable step. What about as the glaucoma progresses? Well, as it progresses, most people add a second drop, maybe a third drop. We'll talk a little bit about that being a changed algorithm, but traditionally that's been very true. And this study was done in 2023, so this is real time for the most part. Do you incorporate laser or MIGS, early surgical intervention versus, end-stage trabeculectomy or tube? And the answer was about a quarter do, but the vast majority still manage with drops. And I think that's where most of us are. The question is, are drops as useful as we believe they are? And the answer is maybe not so much. On a scale of 1 to 5, how confident are you that your patients fully comply with their medication prescriptions? I would say the answer for me is probably about 50%, somewhere in that gray zone. Very confident? Not very confident at all. I've seen enough patients, and I was telling Jen, I saw 37 glaucoma visits today, busy practice. I'd say probably half took their medication on schedule. The other half, we had a little discussion, got them back on the horse and got them going. But there's a lot of different reasons that people don't do what they should do. And some of them are just life. I understand that, it's sometimes hard. And why is compliance an issue? Well, compliance is an issue because vision loss is the endpoint of non-compliance, right? And blindness is the endpoint of vision loss when it expands to its end stage, right? So you can do a lot of things. I find that one of the biggest issues, patients are just challenged by getting drops in the eye. I just put some drops in my eye this morning because I picked up a little cold traveling and had a little sniffle, and my eye wasn't looking particularly helpful. And tested for COVID, I was negative, so I was going to wear a mask, but I looked a little red in the eye. I must have tried 3 times to put a drop of Lumify in, and I missed the first 2. And, I do this 50 to 60 times a day to patients, but couldn't hit my own eye. So I have a real place in my heart for these folks who just don't get it right. Right? There you go. What advantages to your patients for treating, glaucoma with drops? Well, obviously risk avoidance is one. I mean, you don't have to worry about surgical complications. Totally understandable. Simple. Yeah, it's relatively simple. If you keep it simple, I mean, it's easy to put a drop in, relatively speaking. I think when you use it more, you get better. Non-invasive, and that's true. Safety, that's true. So all four of those kind of occupy the same space in my mind. You are looking at an opportunity to do something that has a relatively equal occurrence at the early levels of control, and something that is manageable, it's reversible, it's revocable, versus a surgical procedure, which is a big step in a direction that many of us either don't have the background in or just aren't comfortable with the people that we work with to do that procedure for us. Here's the big question, though. Are drops really benign? And the answer is absolutely not. I get to see it every day. You're going to see it every day the longer you manage patients topically. There's a lot of good literature to support this, and this is really important stuff. Important science, I should say, because complications like this cause patients to stop taking medication. There's a really high rate of non-compliance to topical glaucoma meds that and contributes directly to disease state. The two things in my mind that are the biggest contributors to disease state progression in glaucoma are, one, every major study, back page news, but really important, low diastolic blood pressure, which we don't really measure much in the office. And number two, compliance with medical regimens. If everybody took the regimens that we recommended, the rate of progression would be very different than what you see in that gray zone there in the Olmsted. That, by the way, it's Mayo Clinic out in Minnesota, Olmsted County, one of the really large clinics with great EHR systems. And they've looked at massive numbers of patients. I mean, look at that. I mean, the number of patients who go blind on treatment is high, and I certainly have a significant number of those in my practice. I get to see it on a daily basis. So I try really hard to find ways to not have that happen. And we'll talk about some of those. I think the more important thing, though, is the reason that I have bigger concerns is if I'm going to put you on a medication for 30 years, you will see things like hyperemia, periorbital fat atrophy, ocular surface disease, which is almost generative, and then subsequently hyperchromia, pigmentary changes in the iris. And quite frankly, the elephant in the room is topical meds don't work if the patient doesn't take them. This is some really good data, courtesy of IconMed, one of the great glaucoma people in North America. This is out of Market Scope as well, Journal of Glaucoma 2004. Look what happens when you add meds, okay? Patients on 2+ topical meds, how effective is this? If you add a third, you don't see an enormous increase in efficacy. It's minimal. A fourth med, pretty much the same. 22% of our patients are on 3+ meds, which means usually a prostaglandin at night and a combo drop on a once a day or twice a day basis, like a Combigan or Zinbrinza or Cosop. Very common regimen, but that's 3 drugs. And what's the importance of that? Here's a really good study by Jan Paul in 2014 showing the trend line. So you get 33% drop on the first, but only 9% more with the second drug and 13% more than that 9%. So the average there, it's not 13% above 33, it's 13% over existent. And you're really looking at maybe 2 millimeters by adding 3 more drugs, which is 2 more drugs, which is a big issue when you look at the complications of the drugs, which we'll talk about. So when I look for compliance, one of my key points is I try to keep the process as simple and as non-challenged as possible. So prostaglandin first, I'm sure most of you do that. I'll work around the prostaglandin issue. It's a complex subject, but there are patients who prostaglandins are too strong, so you can go every other night and get just the same IOP control with less medication because they have a very high endogenous prostaglandin. Other patients do better taking the drop in the morning, as I said, simply because they can remember to take it. Over time, though, my concern is, am I going to cause changes in the eye that are not in the benefit of the patient? And here's another study. This is Johnson in 2020, very recent study. This is a washout study where the Horizon and Compass trials, where they did 1,400 eyes. They were on 0 to 4 meds. They were screened. They did a pre and post washout IOP. First med got 35%, but look what happens with second, third, and fourth meds. We went from, basically getting about 6 to getting about, with the third med, you're getting about 7. So not a big drop for the additional complications and costs, and quite frankly, the amount of work that you have to do in your office. So that does enter into the compliance process, is how the medications affect the quality of the patient's life, the quality of your office life as far as your staff and everybody working hard to try to get those drugs if you want. And then, by the way, there are very good drugs out there. They should be used, and they are very helpful in improving compliance and vision safety over time. But it's work, so we'll talk a little bit about that. One of the disadvantages of non-compliance, obviously. The other interesting thing, if you want to know a patient who's most likely to lose vision from glaucoma, Paul Lee out of Michigan, when he was department chair there, this has probably been 15 years ago, published a really interesting sort of social behavior study where he looked at the progression of patients and he found a single factor that was predictive. It wasn't the corneal hysteresis, it wasn't the starting levels of RNFL or GCC, it was, or cup to disc ratio, or even IOP. It was a patient who missed 3 consecutive visits without cause, telling you that they just don't care about this disease. And therefore, no matter what you do topically, you're going to have a tough time managing. Here's a really interesting study on multiple meds in glaucoma and the incidence of dry eye. This is Rossi in Herb as well in von Grafie's Rossi's in European Journal of Ophthalmology, the EJO. Both of the studies show pretty much the same thing. The incidence rate of dry eye in glaucoma patients was ridiculously high in large populations. I can attest to this, and we're going to talk a little bit about treating that, because I think that's a big part of the compliance problem, is if they have another problem that is developed as a result of the treatment, that's called a complication or an AE, adverse event. If you don't treat that, they are very likely to deviate off because they don't like the way it looks, they don't like the way it feels. It's just not a good process for them. We have, my partner, Rob Neuiker, one of the really talented glaucoma people in America. I think he's probably one of the largest ocular surface treaters in the Northeast. I'm not far behind him, but nonetheless, I mean, every patient I see of his is on some form of ocular surface treatment just to calm the eye down and keep the effect of the drugs to the lowest level so we can get the best compliance possible. And here's what happens in patients without dry eye symptoms. You have a much higher rate of compliance in that first year than you do in a patient with. So if a patient has DED, you have an almost 30, just about a 27% drop, 26% drop in compliance, which is obviously, that's about a 33% overall drop in compliance just because they have symptoms. So the point here is, if they have symptoms, treat them. There are lots of good therapies, and I saw that Selena McGee, one of our super talented colleagues, one of my favorite people, is going to be doing part of this 3-part program. She's going to talk about that. Pay attention to what she says. She is the master of that moment. Learned so much from her over time. And she's going to tell you the same thing, that if you can keep your patient comfortable, your compliance is going to increase. This is an eye that has, mild staining, sort of typical. Look at that. When you go off of blue and you go on the white, look at what's happening to the cornea from glaucoma drugs. Ocular surface improves with less topical drop exposure. That's not rocket science. This is Justin Schweitzer, one of our really, really top colleagues, and I'm sure Justin's probably participating in this in some way. Saw Mitch Ibox going to join us next week. So Mitch was a previous student of mine and one of the super bright rising stars in our profession as well. They both are going to talk about just this issue of compliance is directly related to quality of exposure, and the less drops you use to get the same effect, better off you are. But here's the problem. If you don't have enough drops and you have a lot of fluctuation because patients are non-compliant, then the progression changes. This is the AGES study, and one of the classic takeout slides of the AGES study was the orange group, which is low mean IOP. Everybody in that group, no one had a pressure in that group greater than 18 throughout the whole study period, which was 100 and some months, right? Almost 7 years. On the other hand, if you had an 18 or above, look what happens. You're the blue line, look at your progression. So the key here is to use the minimum amount of therapy to produce the maximum effect and decrease the compliance variation so that you have increased stability of IOP response. And that's really the nexus of this whole process. So study is a really good example of that. Here's another interesting study. This is out of IBOS in 2011. There's more recent ones I don't have in the deck because my computer crashed. Again, Dr. Icahmed's slide, so thank you very much. He's lectured for us at NGS several times. What happens when you treat a patient chronically for long periods of time is the BAK causes damage to the trabecula. It causes fibrosis and sclerosis of the TM. And that's a problem. So we need to balance the process. I tell every patient when they walk in the door that you have a long journey in front of you, and I'm going to be here for you every step of the way. Anything you need, anything I can help you with to make sure that you have good vision for the rest of your life. That's my goal and my responsibility. To that end, in your lifetime, I'm going to use medicine and surgery to balance your control so that we can make sure that you have great vision forever. And patients want to hear that. That's a commitment they love to have. And that's what I do. And I can tell you one of the things I've done is I've moved away from BAK-based meds. We'll talk a little bit about that in a couple of minutes. It's been a life-changing moment for many of my patients. And for me, because I see the literature that supports the idea that the less BAK that you put on the eye, the better chance you have of that trabeculum staying healthy and younger over the course of the patient's life. So let's talk a little bit about some new diagnostic tools to improve compliance. I have to say, if I were to summarize this into a single moment, the first bullet is it. This has changed everything in my practice. It used to be such a battle to get a visual field done. I don't know how many of you are using virtual fields. I've been blessed to have done the beta test on at least 6 of the current 7 ones that are, well, 6 of the 6 that are out there now. One of them dropped out. And I have settled on a couple of them that I love, but every one of them has been very well done. And they are a generational technology change. I think the biggest issue with these is what they do for you as a doctor to get your patient, to get information from your patients that is super important in your consideration on what you're going to do next. Is my regimen working? Do I have to add another drug? And if I'm going to do that, what should I do? Should I do SLT? Should I consider Durysta? What about an iDose TR? There's lots of possibilities out there, but the only way to really understand it is to have the ability to analyze both your OCT generated information and visual fields. Patients hate visual fields. Universal statement. I haven't met one that did. This has changed everything. I can't tell you the number of people who have said, oh my God, I don't want you in the field. I said, look, I have a new technology. Let's go ahead and do that. If you don't like it, then we'll talk about how we're going to do this going forward. 95% walk out and say, wow, that was pretty easy. That's because it was. Virtual visual fields have changed our practice tremendously. It's given me the ability to run numerous, well, tremendously higher levels of visual fields per day without impacting my technician-based time. And it allows me to get really outstanding information that is easily acquired in a simple situation. They can sit in my office, they can sit in the waiting room, they can lay upside down in a chair, it doesn't matter. You can do these tests anywhere. If you've seen people play video games, they're not always in the best posture. The problem with the big box, and this is, by the way, this is Radius. This is the one that I have taken to my glaucoma side of the practice because it has the best data. I'll talk about that in a second. They're the only one that has done a head-to-head FDA trial against Zeiss Humphrey boxes, HVFs, and they came out fantastic. So as a device, you can trust the glaucoma outcomes on this. They also do GPA analysis. Everything that Humphrey does, they do, but they do it at a price point that's about 1/4 of what a Humphrey costs. And this goes with me everywhere. Tomorrow I have a different office. This is in my car. I take it with me around. I have a couple of these. And I can do 2 fields at once, just 2 different rooms. Sometimes today I did 14 fields. I kept count. Yesterday I did 12. I might do 50 or 60 this week. When I had to do the box, if I did 20 a week, it was a lot. So compliance is helpful. This helps with compliance because patients will do testing that you really need without the pushback that you've had. So is the big box over? No, it's not over. It's just that, like anything else, technology has leaped forward. So strongly consider this type of technology for the practice. I love this for glaucoma. The other company that I really enjoy working with is All Eyes. All Eyes has a different version. They certainly do the glaucoma part. They have a few more fields in a sort of general way. They have an estrument and they have a ptosis field, which is all good. But the difference there is this is more of a general practice unit as I see it. That doesn't mean that the Radius can't do general practice. This does acuities, this does color vision, gives you really a comprehensive report of EOMs and pupil distribution, or pupil activity. So I like it. I don't use this part as much. I don't have a general practice. I have a very specific medical office, But what I really love is this. I think other systems have to look at how they're going to do this. This avatar, this person named Annie, is amazing. She is so engaging and so lovable that I will frequently walk by the room, which I did today. She'll be saying something along the lines of, "Oh, you're doing really well on the test. Keep up the good work." And the patient will literally respond to her and say, "Oh, thank you so much." Understanding now that I have a patient who's totally bought into this test. And one of the reasons that they don't mind taking it again in 3 months or 4 when I really need to know is my goal pressure where I need it to be? And am I going to get that place where I can keep this patient stable? And is the patient compliant? Because visual fields and OCTs are your two weapons to measure that against, right? So important new technology. Another great technology, which you have, but probably many of you may or may not have looked at the next level of this, which is the ganglion cell anatomy, which I believe really represents the better view for compliance. And there's a couple of reasons for that. We'll just give you just a minute or two on this. But if you look at the data, especially by Don Hood, Raza back in 2011 in Vision Science, and Drazo in Vision Research in 2007, even way back in the 80s with Heil and Lundquist, that's Anders Heil, who actually wrote all the algorithms, most of the algorithms, along with Mike Patella for the Humphrey Visual Field System in the big box, right? Really just incredibly bright people and such heavy level contributors to the glaucoma space as far as knowledge. The point here is that that analysis was not done, it was done with RNFL work, right? So when the machines first came out, everything was RNFL. As the algorithms improved, they were able to include ganglion cell work. This is an original mapping by a gentleman named Dr. Don Hood, one of the bright minds in eye care, and one of the people that if he writes something, I immediately sit down and find time to read it. No matter what he writes, I learn, and I think you would too. But what he noticed was that when he was mapping the ganglion cell complexes in order to build the algorithms, that inferior zone there was more vulnerable, and you get that typical wiper defect or squeegee defect, depending on who you listen to, but same concept. It's vulnerable and produces that effect. So the question is, does ganglion cell give you a better ability to watch compliance? And the answer is in this study, and I'll show you what that means. So in the RNFL, you have some real limits. RNFL has a wide base of normality, anywhere from 750,000 to about 1.5 million fibers. And in doing that, trying to write an algorithm in a zone that is double its base in the disease state space is really difficult. Second, ganglion cells are somewhere between 800 and 1 million fibers, so you have a more narrow band of normal distribution. So it's easier to look at that and check against progression, which speaks indirectly to compliance. Actually, most times it's direct, but sometimes it's indirect. And as a result of that, this device can help you understand whether your goals, objectives, and implementations are getting where you want to go, and is the patient working with you to make sure that you both are getting to the same place. This is a fantastic study, 277 eyes, 188 patients. He looked at the differential diagnostic capacity, ganglion cell versus visual field. And I want you to look here. The average time to identification of statistically significant progression in a patient going from glaucoma suspect to glaucoma status with OCT ganglion cell was 2 to 3 years, whereas visual fields, it was up to 6 years. And that's what you see in practice. I mean, if you're in that early space, and that's where most of us participate, thankfully, hopefully none of you are working with that, last 10 axon patient who's had multiple procedures done surgically, and they're just not going to make it, and the eye's going to go blind. It's a very sad time. But here in the early phase, which is where we all work, all of our ocular hypes and our glaucoma suspects, this device gives you a very different perspective on what you're achieving clinically with your interventions. It does it faster. This was done with a traditional box. I believe that if you take this and you add the ability to do 2 or 3 fields a year comfortably in a patient who doesn't push back against that, now you've raised your level of knowledge and your perspective on the disease state to a whole different zone, and I think really manages it long term. But here's one of the reasons that the RNFL has a problem. This is Achilles heel 1. and that is it has a floor. So it means that at some point, you can't go any lower on the measurement. And that's somewhere between 50 and 60 for average patient. So 55, let's say. And the reason for that is the RNFL starts to be replaced. Losses in the RNFL start to get replaced by astroglial cells, which are about the same thickness. So the machine's just measuring thickness. It's in theory telling you RNFL, but anything that contributes thickness to that measurement is going to give you a number. You'll see that that patient, and I could give you half a dozen examples today, RNFL is just absolutely floored. But the ganglion cell, because it has so many other ways to analyze, it's much more dense, one, it's more central, lost later in the disease, and the fact that the algorithm is much tighter. The average RNFL can vary 6 to 7 microns. The average GCC to demonstrate progression is 3 microns difference. So it's a much better look. I love having this with the visual field as I move through the disease state to help me understand where I'm at with my recommendations. And also, quite frankly, either if the patient tells me and is truthfully doing it and we're moving forward, then my recommendations are wrong. If I am certain that the patient's non-compliant and I see this moving forward, I'm getting a much earlier look at that lack of compliance and a chance to move into a more surgically directed opportunity, which is what we're going to talk about here in a couple of minutes. High density anterior segment OCT, the forgotten technology. I cannot tell you what a valuable tool this is for the following reason. You can measure almost anything now in the anterior segment with really high level of accuracy with a simple HD-AS OCT. It's incredible what's available with a simple look at the anterior segment. I have a student teaching program on faculty at 7 schools here in the States and then University of Melbourne in Australia. And I have students from most of the schools over the course of a year. Well, over a course of 2 or 3 years, pretty much I have somebody from everywhere. This is something that's not really taught well at the school level as I've seen it. Maybe some schools that I don't teach them do it well, but the students come in and are like, oh my God, this is amazing. Yes, you're going to do gonioscopy. That's a different issue. But this is a more accurate rendition. It's a 2-second test when the tech's in there, getting the RNFL and the GCC. Anybody with glaucoma, anybody who's a suspect, should have a standard HD-AS OCT done at the time they have their other testing done, because that person at the top and that person at the bottom are the same person 7 years apart. And what happens is that angle has slowly crept to a close or just about closed. The pressure's rising. You're adding medication thinking the open angle component of this is getting worse, when in fact what the patient really needs is one of 2 things, either a PI to give you a bridge, a couple of years, maybe 3 to 5, lower pressure with good, better flow and a more open angle, or just a cataract extraction. Either of those are going to work. But what you don't want to do is miss that bottom patient and have them progress over time while they're compliant and you're just not catching the moment. So I think this technology, along with the notable increase in the ability to do a comfortable visual field, really changed the game for the average clinician and people who are doing a lot of early work in glaucoma. Let's talk briefly about this. This is game-changing as well. Tomography is the new horizon. For those of you who haven't followed the space of tomography and glaucoma, Chandler and Grant's epic book, the glaucoma book, the book that sort of stood the test of almost 3 decades of time. They were Michigan folks and super bright and very, very clinically directed. They started doing tomography way back in the day. They also did all of the modeling to understand what the resistance to outflow, where the resistance to outflow took place. And they found that 80% plus of the resistance to outflow takes place in the trabeculum Slam's canal. Well, the only test that actually measures that is tomography. IOP is a 5-second to 10-second test. You do it 3 or 4 times a year. Maybe you've seen the patient a lot. You might do it 5 or 6. So you may have a minute of the patient's life. Tomography, on the other hand, is like the A1C and hemoglobin. You're getting a view of that patient's time over, that view of that patient's behavior over time. And I'll show you some data that really enforces or reinforces the idea that there are very, very good things at the end of the road when you have this type of tool to join together with everything else you're doing. This is where compliance starts. I can measure what the patient's doing. And the problem with IOP is pretty simple. it varies so much that there's no one measurement that's meaningful over the course of time. I mean, all measurements eventually become meaningful, but no one measurement. Here, a single measurement tells me exactly what the patient's doing, and I'll show you why here in a minute too. So sonography measures aqueous outflow, right? Resistance to outflow, right? What the flow is. Outflow is decreased in glaucoma. We know that. That's why the pressure's up. Increased resistance at the TM causes an increase in IOP. And therefore, if you look at the overall, IOP is directly related to the aqueous humor production, as you all know. So more IOP, more aqueous humor production, or the inability of the produced aqueous to exit the eye, increased IOP. It's inversely related to aqueous humor outflow. So therefore, if the aqueous humor outflow is higher, IOP goes down. The rate of aqueous humor outflow is constant, but the rate of aqueous humor production isn't. That's why IOP varies. So if the rate of outflow is constant and you're constantly changing the rate of production, as we do nighttime versus daytime, recumbent versus upright, then you see the variations that we've become adapted to as being the diurnal variation, which is an indirect look at the outflow. Up until recently, we didn't have the ability to do that. We couldn't read the outflow. Now you can. So impaired outflow facility, absolutely the underlying cause in glaucoma. Outflow predicts measurements in and out of the office, whereas IOP does not. Let me show you a graph. So this is a study by Dr. Frank Falk, who actually is the inventor of the device. It's called the Falk Multi-Medical System. I've had this for, well, before COVID, so for about 5 years. I've done well over 4,000, because you get 250, yeah, easily, probably 5,000 to 6,000 measurements in that time period. Because you get an individual activator for every patient that's a sterile chip. So you put it into the device and it does the work. So here's an interesting representation. So this is a study of about 180, I think it's 87 patients. And what he looked at here was what the outflow, which is the x-axis on the bottom, versus the IOP, which is your y-axis on the left. So if you have a pressure of, let's say you want to have a pressure of 15, constant, outside the office. The outflow that you measure can predict that. So to get a pressure of 15 on a regular basis outside of the office, you need an outflow of about 0.25, right? On the other hand, if you want a pressure of 12, you need an outflow of 0.35. All I did today on all 37 patients was measured outflow, and I also did regular tonometry as well. And we looked at the two of them and compared. And what you find is that the pressure is interesting. The outflow is remarkable. And for patients, I set mine by outflow facility. And when they come back, for a lot of reasons, let's say you put them on a drug, we'll talk about that drug here in a second, put them on a drug and that outflow facility, the pressure doesn't change much. Let's say the pressure was 25 when you started them on Vyzulta, and the Vyzulta drops them to 21. Not a bad result, less than 20%, but you know, it's a start. There are other drugs that you think might do better. So instead of adding another drug, what you really want to know is what was the outflow facility before you started, and what is the outflow facility now? Because there's a third part to that equation, that triangle. And the third part is, let's say the outflow facility was 0.16, and the Vyzulta raised it to, when it was 25, and the Vyzulta raised it to 0.25. Well, that's a 40% increase in the outflow facility against a 20%, about 20% drop in pressure. So what is missing in that equation? You just didn't know what the peak IOP was when you started that patient, and you probably never will because you're not having the patient in the office for days on end. This gives you the ability to have literally an A1C type of measurement. I love this relative to my compliance considerations because I can tell the patient's on medication. IOP doesn't always tell me that. This tells me, and it tells me very, very clearly and objectively without any issue. Talk a little bit about drugs, specifically for this purpose. All right, there are two drugs out there that really matter relative to compliance because they produce better results with the same dosing. We talked about that early. Less use of drugs with the same or better outcome. Both of these drugs achieve very similar outcomes, and here's why they're important. So this is rocklatan. It's a combination of latanoprost and roperescent, which is notarsodol. Metarcigil. It's a ROCNET inhibitor, and it activates a change in the protein structure, the actin proteins in the trabeculum, and it relaxes it, and it makes it easier for the fluid to flow through the trabeculum. So it's a true trabecular outflow enhancing drug. That's its mechanism of action. That's why the FDA approved it. Look what happens in the real world. So you go over to the left set of histobars, the dark green and the yellow. So the dark green is rocklatan, and the yellow, the pumpkin color, is latanoprost. That's 0.005% standard xalatan. But this is comparatively, right? So this is intent to treat. This is area data from the clinical trial, the FDA trial that they got the approval on. At 20% request, so if you only need 20%, like we did the OAT study, you're fine. You really don't have much need to do. And that's why the insurance companies and the pharmacies won't give you the drug, because they're saying, look, at 20%, which is what everybody, all the clinical trials talk about, this drug works great. It's clinically insignificantly different. And I would say that I can't disagree with that. But look what happens when you get a little further out. Now, if I want 30%, rocklatan is twice as likely to give me that response as latanoprost generic. It is 2.5 times if I want 35, and it's 3 times more likely if I want 40%. Well, one of the great pieces in compliance is you want the maximum medical response from whatever drug you use. So if you use a drug that has a lesser capacity to do that, you're simply adding to your compliance load, because eventually you're going to have to put another drug on here to get anywhere near that response. And I showed you earlier, adding second drugs don't work as well as first drugs. So this is a drug you should fight for. I have no stake in the company. I don't own any stock in the company. I use a lot of this drug. I have hundreds of patients on this and Vyzulta, probably 400 or 500 in practice. And this is a go-to drug for me. I will fight for PAs. I'll fight for Medicare. I'll fight for letters to the CEOs, chief medical officers of companies. If I can show efficacy with this that I don't get with latanoprost, I think that should be a given, that we should have access to these. Because what it's doing is changing my compliance capability. Vyzulta, exactly the same. The only thing about rocklatan, just put that out there, side effect profile is much higher. The IOP control, I think, is almost identical. You see the same thing with Vyzulta. Here you have a nitric oxide donating drug, which has a similar effect on the trabeculum in that it produces relaxation. Nitric oxide relaxes smooth muscle. The number one drug that we use nitric oxide for is erectile dysfunction drugs. So Cialis, Viagra, et cetera. They are nitric oxide donating drugs, and they relax muscles to allow blood to flow. Here, they relax muscle to allow aqueous to flow. Same pattern here. You know, at 20%, about the same. 25%, a little different. 30%, big difference. 4 millimeters, which is 35%, and then 5 millimeters. There is no comparison between this drug and latanoprost. So again, drug worth fighting for, just fewer side effects on this one. So these are great compliance drugs. Here's another really good reason why both of these drugs, and I don't have the rocklatan data here, it's identical. This is a study of patients with lower IOPs or normal tension. This is a subset study out of the rocklatan or the Vyzulta study. Long story short, this drop of almost 5.2 millimeters is extraordinary in a normal tension patient. The average drop for Lumigan, Xalatan, and Travatan-Z was about 2.5. So both of these drugs have really high level capacity at that group of patients, which makes this a compliance enhancer because it gives you far better IOP control with a lot less intervention. Another great drug. Love this drug, and it's not because Taya has a sponsorship. I use this all the time. I had no idea they were sponsoring tonight. This is a great drug because it's the first non-preserved drug, no BAK. Remember I mentioned earlier, BAK eventually damages trabecular meshwork, that has head-to-head capacity against a non-generic drug, okay? So this went straight up with latanoprost at 12 months out, no statistical difference in IOP control. All other previous drugs didn't have that level. They were 20% or so less. They weren't bad drugs, but they weren't as effective. This drug goes head-to-head with any drug out there and has great long-term value because look what it does to the eye. Look at the symptom drops between the initial and the eventual outcomes. It's tremendous. And I see that in my patients. Within 2 to 3 months, their eyes are white, they're quiet, they're happier, their ocular surface issues are generally resolved. This is a very good drug for a large number of patients. Another drug worth putting up a battle for and getting the prior authorization. So all three of these really represent high compliance enhancement drugs because they give you what you want. They decrease the side effect profile, they increase patient compliance from that perspective, and they control IOP at a much better level than the other drugs. We'll probably finish up a little bit with this. We've got a couple of minutes left. So let's talk about next steps in compliance. Well, I said earlier, medication and surgery are part of the profile. There is an absolute rising tide in the arena of SLT. There are so many different ways SLT is being discussed and used. It's almost difficult to even have a discussion within a minute or two. But I'm going to give you a little 20,000 foot down view. First, we now have 15 states by my count that allow us to do this procedure. And I will tell you that in the future, given all of the research and the data that's been accumulated over the last 5 to 7 years, this is someplace that you need to have access to either through referral or directly by providing the service in order to have that combination of good compliance with medicine and surgical intervention. So let's talk a little bit about SLT. This is the old pattern, right? This is where we were. We had 1 med, we had 2 meds, we had 3 meds. This is from Malia back in 2014, and then Lichter, Paul Lichter was a really great glaucoma guy back in the early 2000s. And then you went SLT, and then they went to filtering surgery and shunt surgery. Now we have about 25 MIGS procedures in the dead center of that. And it looks a lot more like this, right? Again, thanks to the icon med. This is a new algorithm. That's the legacy up top. Look at the one on the bottom. Drug delivery, SLT first. That's an interesting concept. Should we avoid drugs altogether? That discussion's out there, and you're going to hear that from a lot of people. I'm not saying that tonight. I think medication still has a very vital role, but I do believe that the role of that type of surgery, which is minimally invasive and maximally effective, is going to be a major component of your decision making going forward, particularly on the compliance side, because when you do that, you achieve some really interesting things. So let's quickly talk about the LIGHT study. That was the biggest study recently. And I just want to show you, 36 months out, about 75% of the patients without medication were at IOP control based on the goal pressures that were done before the study was instituted. On the medicine side, it was about the same. So it wasn't notably better than medicine, but it was not inferior. The difference was quality of life for the patient was significantly better. And in the long run, progression was different because laser controls around the clock. And we don't have a single medication other than the PGA that even gets close to that. The beta blockers, the alphas, and the CAIs have no nighttime control. Pressures rise even on medication. PGAs have some control, but not as much as a laser. And the reason is you're not putting a drop in and having it wear off after 12 hours with a laser. The other thing they found was with repeat testing, repeat treatment, you can gain really good outcomes in patients who originally, quote, failed, but in fact, you treat them as early as 2 months on failure. Almost 70% of those eyes at 18 months were at control. So this puts it up closer to about 90%. Is a really impressive data point for all of us to look at. This is the first study ever where it was pure medical, pure SLT, no prior treatments. These were all naive patients. And they use the exact same protocol we've talked about. PGAs first, beta blockers second, CAIs and alphas third. Now, brand new horizon. This may change all of your opinions about moving into compliance with a surgical component along with your medical component. Look at this. This is the direct SLT developed by Belkin Vision. It was bought by Alcon in July. Alcon will be marketing this product. You'll be able to get this in the US in 2025, I anticipate. So huge, huge improvement. And here's what it looks like. Unlike traditional SLT, where you have to have a lens, coupling gel, and a pretty good trigger finger and a nice aim, this actually docks the patient's cornea, finds the limbal junction, focuses on the trabeculum, and when you push the button, in about 2 seconds, it delivers all 100 laser shots at the same time, simultaneously, 1.2 seconds. Patient walks away and they go home. Now, obviously, we're going to check the pressure in a while, but the reality is this is a test, this is a treatment now that can be done very simply in any office in the country, including all optometrists who are well trained to do this. I think this makes our argument for SLT progression on a legislative level much more powerful. I also think that there's a potential for this to become like an SLT center, right? People going for their SLTs, they do this, they could do 200 of these in a day. So we need to get on the train, but I do believe SLT is one of the new dimensions that we want to engage in. Got a couple of minutes since we got a late start. At least I'll finish by 9:30, but since we got about a 5-minute late start. Really interesting new study. It's called the COAST trial. It's another version of SLT, but here everybody went in, had a standard SLT, and then they broke them off after that. And they did this yearly, very low level SLT versus treat them when you need it SLT, which is more the standard, right? And what the goal is to look at the idea of if we give you a low dose SLT every year, a booster shot, as it were, can we control the pressure as well as if you get SLTs periodically? And is there an advantage because we're not treating the trabeculum at that same level? The study is being done by Tony Riolini and Michael Cass, who was part of the Oath study, Mark Latina, who invented the SLT, and Gus Gazard, who was the principal investigator for the Light study. This is a supernova of glaucoma specialists in the United States and outside the US. So great, really excited. Don't know where it's at yet, but shows you that SLT is the hot button right now. So compliance, I use this for compliance every day. Every patient who comes in, and if I have 3 months with you and you are not on medication, my next conversation is, let's go ahead and do a little bit of laser so we can complement your drug use. In my mind, I'm saying, let's do a little bit of laser so I don't have to worry as much about you not complying, therefore progressing. And in fact, that's a true statement. So, and Durista's an internal device that you can use. We use a lot of this. We did. Now we're moving over to this. This, I think, is the future of long-term dosing. This is where most of the research is going on, colleagues, is in sustained materials like this. This is the iDose TR, glucose iDose TR. This is an implantable device. That little element there has the material in it. This has the prostaglandin in it, and it releases it at a controlled rate. Look at the data, though. This is crazy data. I'll finish up with this. So here is the phase 3 and phase 2b data. So at control percentage on the slow release, 93% at 12 months in the 2b and 93% in the phase 3. But look at 24 months. 3/4 of the patients, approximately at 24 months, still under control. And look at 36 months, 70% of the patients are still under control with a single application of that small little device. This is the future of compliance in the long term. Medicines are not going to be the be-all and end-all that they have been for the last 100 years. We will have to find a way to blend together our topical therapies with our initial minimally invasive surgical interventions and then minimally invasive glaucoma interventions in the form of cataract, in the form of MIGS surgery, which we're not going to talk about. So I think the world of compliance is our most challenging, but I take that as a real issue in my practice, and I'm sure you do too. Hopefully presented tonight some opportunity for you to adjust some of the things you do to tune up your compliance concepts. And maybe we can all benefit in the long run from having a little bit of perspective. So thank you so much for the evening. Hope everybody enjoyed it, and happy to answer any questions.